Hi, I'm Dr. Todd Husty with Medical Audit Resource Services, or Marcy as we like to call her, and I'm here to talk about Medicare risk adjustment and hierarchical condition categories. Now, I know I just got a big yawn out of most of you because as a practicing ER physician for 30 years, yes, documentation and coding has never been my favorite subject until I learned more about HCCs. It's actually kind of exciting. Okay, I'm either crazy or by the end of this, you're going to agree. One way or another, risk adjusted reimbursement systems are here and they're here to stay. Let's go through some objectives. I'd like you to understand the differences between fee for service and risk adjusted reimbursement. There really is a huge difference. I'd like you to become aware of the increased importance of your specific documentation in risk adjustment. And I'd like you to appreciate the relationship between thorough documentation and quality of care, both globally and the specific quality of care initiatives. There is a relationship between thorough documentation, thorough care, and quality of care. And I'd like you to understand the documentation requirements for ICD-9. It's going to give us some insight into ICD-10 conversion, which is coming October 1st, 2014, and that freight train is not going to be stopped. And finally, I'd like you to learn the HCC categories and the rules and guidelines, which really tells us which ICD-9s go where. HCC is based on medical risk, unlike fee-for-service that is based on procedures. Certain chronic diseases and some acute conditions make up the hierarchical condition categories, and each condition, which is an ICD-9 diagnosis, is assigned a weight, which translates to a monetary value. The more HCC conditions a patient has, the more financial risk there is to the health plan. Sicker patients cost more to care for, so the more money is made available for the care of the patient through this risk-adjusted program. So here's the process. First, the risk diseases must be identified in order to be evaluated and treated. Secondly, they must be documented correctly, adhering to official coding guidelines, and the conditions must meet. That means managed, evaluated, assessed, and treated, not just listed or coded. Thirdly, they must be correctly assigned the correct codes that represent the conditions by the guidelines of ICD-9 and soon to be ICD-10. Because of the complexities of the system, codes are usually assigned somewhat haphazardly. This results in overcodes and undercodes. Let's talk about undercodes. That means we do not capture all of the codes that are out there. The reasons are doctors don't know the new system. We really don't know the documentation guidelines. We don't know the documentation requirements, like we're not specific enough, therefore it doesn't risk adjust. Maybe we use too many one-word diagnoses, such as bronchitis, diabetes, and hepatitis. Instead, we should be saying chronic bronchitis, diabetes with peripheral neuropathy, chronic hepatitis C. The other part is that doctors are having to do their own coding in EMR systems. We don't really know the coding guidelines. We certainly don't know the HCC guidelines. And the big one is that our reimbursement never depended on ICD-9 diagnosis codes before, so we really haven't been trained that well. Okay, so here's why I actually like HCCs and risk-adjusted reimbursement. The focus of risk-adjusted reimbursement is on early diagnosis, treatment, documentation, and coding of diseases. Oh, and keeping patients well and out of the hospital. What a concept. This keeps medical costs down, leads to better patient care, and it's all through incentives for physicians. Everybody wins. Here are some more diseases and their manifestations that require more than one code. Peripheral vascular disease due to diabetes requires two codes, the 250.70 for the diabetes and the 443.81. Both of these codes risk adjust. CKD is secondary to diabetes, requires two codes, 250.40 for the diabetes and the 585.X. By the way, the X is for what level of CKD they have. Chronic hepatitis due to alcohol requires two codes, one for the chronic hepatitis and one for the alcoholism. It can be active or in remission. It risk adjusts either way. It's a new coding clinic guideline. Both alcohol and drug dependence and their associated physical conditions should be coded, and both have an associated risk factor. So, the correct code for a patient with alcoholic cirrhosis is cirrhosis 571.2 and alcohol dependency 303.9x. Now, that X in the 303.9x for alcohol dependency depends on where they are with their alcoholism. And note that the patient no longer has to use alcohol to justify a diagnosis of alcohol dependency or alcoholism. So a patient who has quit drinking and has esophageal varices related to alcohol cirrhosis, the correct coding would be alcoholic cirrhosis, esophageal varices in a disease classified elsewhere, and alcohol dependency in remission. And if a patient is under contract for pain management, then you might need to be coding drug dependence. In summary, do code metastatic cancer sites, higher HCCs. Do document and code diabetes to include the proper manifestations and code the manifestation as well. Do document the obvious chronic diseases that are being considered when evaluating the patient, especially those that affect patient care or treatment. Do document acute or chronic. And do document thoroughly. You know it in your head. Put it on paper.